Perfect. Well, welcome to all of you for this first seminar of 2023. And we have a really special treat because Dr. Ahun is with us for a special seminar, and she is visiting us in person as well. Very nice turnout for this first seminar. So she is currently a postdoc at Harvard School of Public Health, but she is a McGill product, at least partly. So she completed her bachelor's in psychology at McGill with honors. She completed a PhD in public health at the Université de Montréal, and she was funded by a Vanier Scholarship and the CIHR. And she is co-founder of McGill, the McGill Black Alumni Association, as well as a founder of the McGill Black Mentorship Program. She's going to be talking to us today about maternal depression and childhood development. So, it's a topic of huge importance, and we've got a lot of interested faculty here today, and students and trainees. So welcome, Marilyn, and please go ahead.
Thank you very much, Dr. Dasgupta, and thank you to the RIMUHC Core for having me present with you today. So just to give a general overview of my talk, I'm going to start by talking about a little bit of my academic career and research program and how I got to where I am today. I'll then present to you the findings of 3 different studies that I've done on the impact of maternal depression on various child outcomes, and then close with some key take-home messages. So as Dr. Dasgupta said, I started my academic career right here at McGill doing a bachelor's in honors psychology. And this is where I really developed my interest in child development. I was able to return to Ghana, which is my home country, to look at the impact of maternal health on children's health and development. I then went on to pursue a PhD in public health, where I furthered my interest in child development by examining the impact of maternal depression on children's cognitive development. And I did this using Canadian data, and I'll be presenting to you some of the findings from that work today. And this was done at the Université de Montréal School of Public Health. And then over the past year, I've been working as a postdoc in global health at the Harvard Chan School of Public Health, where my research focuses on the implementation of early childhood development programs in global contexts. So over the course of my career, my research has really been driven by the idea behind the DOHAD hypothesis, which is that we need to examine the early childhood environment to better understand the etiology of health problems in adulthood. And this graph here nicely summarizes the importance of understanding the early childhood environment. So we have here on the y-axis, the risk of chronic non-communicable diseases, and on the x-axis, the life course. And we see that interventions that focus on the mother and infant dyad or the early childhood period have the greatest impact on decreasing this risk of chronic non-communicable diseases across the life course, more so than interventions targeted in childhood and adolescence or adulthood. So in order to really ensure that we can decrease the risk of health diseases later on in life, we need to target interventions to this crucial early developmental period. And in my research, I focus on a variety of outcomes, but particularly mental disorders, as many of them have their onset in childhood, with about 13 to 20% of youth worldwide experiencing mental health problems. And the reason that I conduct my research in global context is because despite almost 9 out of 10 children in the world living in low and middle income country contexts, the majority of research on children's mental health problems focus on children in high income countries, with about 90% of studies being conducted in these settings. So with all of these different factors in mind, the overarching objective of my research is to identify the mechanisms through which parental mental health and parenting behaviors, both of which are important factors of the early childhood environment, impact child development and mental health in global contexts. And I work towards this objective through 2 research axes. The first is an observational research axis that aims to identify the mediators and moderators of the associations of parental depression with child development and mental health, basically trying to understand why and for whom being exposed to parental depression leads to negative impacts on children's mental health and developmental outcomes. The second axis aims to design, implement, and evaluate interventions that support caregivers to promote children's development and mental health. And so findings from the first axis could inform the development of interventions for the second axis. In my presentation today, I'll be primarily focusing on research conducted as part of the observational research axis. So my research has really been guided by the work of Goodman and Gottlieb, particularly their developmental model for the transmission mechanisms. And this model was developed to identify the different factors that explain why and for whom maternal depression has a negative impact on children's mental health outcomes. Specifically, they identified 4 potential mediators of this association, namely maternal cognitions, behaviors, and affect, or broadly speaking, maternal parenting behaviors, a stressful family environment, innate dysfunctional neuroregulatory mechanisms, and genetic factors. They also identified potential moderators of this association, so factors that could increase or decrease the strength of this association. And they focused on the timing and course of maternal depression, child sex, and paternal characteristics such as parenting practices and paternal depression. Within my research, I wanted to expand this model in 2 specific ways. Firstly, I wanted to understand whether these identified mediators and moderators applied to other child outcomes, specifically children's cognitive outcomes. Did these same factors have the same mechanisms when considering other child outcomes? The second way in which I wanted to expand this model was to understand whether all of these different mediators and moderators play out in different social and cultural contexts. If we take maternal parenting practices as an example, in many high-income country contexts, children are raised in nuclear families where either the mother, the father, or both are the only adults who care for the child. However, in various low and middle income country contexts, this is not the case. There are many other adults who are actively involved in caring for children, and it therefore may be that parenting practices aren't a mediator in this context. And so we need to be able to test these theoretical models in different contexts in order to understand how best to design interventions that are culturally and locally appropriate. So the first study I conducted to test this model was a systematic review of the association between maternal depression and children's cognitive outcomes. And this work was published in 2021 in Psychological Medicine. So we started off with what was already known in the field. We know that maternal depression is negatively correlated with children's cognitive outcomes, and that the evidence of sex differences from narrative reviews is mixed. Additionally, no meta-analysis to date had explored sex-specific estimates, so it wasn't clear whether boys or girls may be more affected by maternal depression. There were, however, existing hypotheses that suggested that boys may be more vulnerable than girls. Firstly, due to the maturational advantage of girls and cognitive skills in early childhood, and secondly, due to the vulnerability of male fetuses, which is more applicable to antenatal maternal depression. So this stems from research that shows that male fetuses are more susceptible to the insults of antenatal maternal stress and more likely to suffer the neurodevelopmental consequences. And so potential mechanisms here that might lead to boys experiencing more cognitive problems is being born prematurely or having low birth weight. And really here we are trying to better understand whether the impact differed between boys and girls in order to inform the development of interventions and tailoring them to boys versus girls. So the overall objective of the study was to perform a meta-analysis on sex-specific estimates of the association between maternal depression and child and adolescent cognitive outcomes. So we used the PICO method to identify the framing of the study. Specifically, the population was mothers and their children below the age of 18 years or 18 years and below. The exposure of interest was antenatal and or postnatal maternal depression. And we specifically focused on observational studies with respective longitudinal design. And finally, our outcome of interest was any measure of cognitive development. So we conducted a systematic review of articles across 7 databases and used random effects meta-analysis to estimate the sex-specific estimates. And we've decided to use Hedges G instead of Cohen's D to account for relatively small sample sizes. And we also assessed the risk of bias of the different studies. So after identifying about 9,000 studies through the literature search, we whittled it down to 12 studies to include in the meta-analysis. And these 12 articles use data from 8 unique data sets, mostly from high-income countries, with only 1 study having data from a middle-income country. And the sample sizes ranged quite significantly, with about a mean of 400 and about 50% representation of boys and girls. And there was an even split in the use of clinical versus subclinical measures of maternal depression. So in terms of clinical measures, these were particularly when women were diagnosed with depression using measures such as the SCID, versus subclinical measures where mothers self-reported their depressive symptoms over a specific period of time. And only 2 studies measured depression antenatally. So most of the results we'll be presenting today are particularly relevant for postnatal maternal depression. And finally, a variety of cognitive outcomes were used across the studies, with most of them using the Bayley scales for infant development and exam scores, such as math, writing, or reading scores in school. So overall, what we found was that maternal depression was significantly associated with cognitive outcomes in boys. And so for every, we found that overall there was relatively small to moderate a negative impact of maternal depression on boys' cognitive outcomes. However, in girls, this association was not significant. And so we can see here that most of these studies had non-significant results when looking at the impact of maternal depression on girls' outcomes. So if we come back to Goodman and Gottlieb's model, our findings suggest that child sex does work as a moderator of the association between maternal depression and children's cognitive outcomes, and that boys are more negatively impacted than girls. Moving on to the next study, we wanted to explore the extent to which this differences between boys and girls also applied when looking at mediators in this association. And this was done using data from a Canadian cohort. And again, this work was published in Psychological Medicine in 2020. So our starting point for the study was knowing that boys exposed to maternal depression are more likely to experience poorer cognitive outcomes than girls. And we know that factors within the home environment, such as maternal parenting practices, do mediate the association between maternal depression and children's academic performance. But as children get older, we know that they become less dependent on their parents, and modifiable factors outside the home environment may come into play as mediators. And in this study, we were particularly interested in school engagement, so the level with which children interacted with their learning environment, and peer victimization, so the experience of being insulted, hit, or bullied by friends, could potentially mediate this association. And again, we were interested in the moderating role of sex here as a way of better understanding how to tailor interventions to specific populations. So overall research objective was to examine the mediating role of school engagement and peer victimization in the association between maternal depression and children's academic performance. And we wanted to explore the moderating role of child sex in these mediation pathways. Data for this study came from the Quebec Longitudinal Study of Child Development, which is the birth cohort of singleton children born between 1997 and 1998 in Quebec. For this specific study, we had a sample of about 1,000 families, where about 75% of them were of middle to high income socioeconomic status, about 84% were of European ethnic origin, and the prevalence of maternal depression was about 11%, which is similar to the prevalence of maternal depression in high income countries, and about half the sample were girls. So in this data set, we asked mothers to report on their own experience of depressive symptoms using the Center for Epidemiologic Studies depression scale when their children were aged 5 months, 1.5 years, 3.5 years, and 5 years. So we had 4 different measures of maternal depression. And then for our mediators, we had teachers and children report on their level of school engagement, and we had different dimensions of school engagement here when children were 6, 7, 8, and 10 years. And we also assessed peer victimization from mother, father, teacher, and child report at those same ages. Finally, for cognitive outcomes, we used children's scores on a government exam that all primary school children take at the end of primary school in Quebec. And here they were assessed on maths, reading, and writing scores. In order to ensure that there were no confounding factors in these associations, we adjusted for potential confounding variables at the child, maternal, and family level. And overall, we used structural equation modeling to test the associations between these different variables. And so within this model, we were able to estimate multiple regression associations, regressing our outcome onto our mediators and our exposure, and regressing the mediators onto our outcome of interest. So for simplicity's sake, I'm only showing the results for the mathematics score here, but the results were relatively consistent across the different exam scores. So in both boys and girls, we found that maternal depressive symptoms were negatively associated with academic performance, which is in line with what we know in the literature. But the differences we found were in the mediators. So for boys, maternal depression wasn't associated with any of the mediators, but their level of engagement, so we had cognitive school engagement, behavioral school engagement, and emotional school engagement were significantly associated with academic performance. In girls, however, the mediation was significant. So maternal depression negatively impacted girls' cognitive and behavioral school engagement, and this in turn influenced their academic performance. So again, when we come back to Goodman and Gottlieb's model, we see that in the context of children's cognitive outcomes, school experiences are also a meaningful mediator of this association. Furthermore, we find that child sex doesn't only moderate the direct association between maternal depression and children's cognitive outcomes, but it also moderates the indirect associations. And so, for example, if we were designing an intervention that targeted children's school engagement as a way of mitigating the impact of maternal depression on children's cognitive outcomes, it may not have the same impact on boys as girls, and so would require some additional thinking to tailor it for the right population. In the third and final study, we focused on mental health of children exposed to maternal depression, and we were looking here at children as young adults. And this was done using data from South Africa. And this work was published in 2020 in JAMA Network Open with colleagues from South Africa and McGill. So the starting point of this study was really the discrepancy in the prevalence rates of maternal depression in low and middle income countries, where it ranges from 20 to 25%, versus high income countries, where it ranges from about 11 to 13%. But despite this discrepancy, a lot more research has been conducted in high income countries. And furthermore, there are few studies that have tried to understand the mechanisms of this association in low and middle income countries. And we do know that adolescents and young adults exposed to maternal depression in childhood are more likely to experience internalizing symptoms such as depression and anxiety. And in high-income countries, we know that a family's socioeconomic status may moderate this association. Specifically, children who come from a low socioeconomic background and are exposed to high levels of maternal depression, so is sort of experiencing this double adversity, are more likely to experience mental health problems later in life. But as I mentioned earlier, there are different social and cultural contexts to consider in low and middle income countries. And so it's possible that we may not necessarily find this association, or it's possible that we might find it, but we won't know until we test it. And so the objective of this study was to examine the moderating role of family socioeconomic status in the association of maternal depression with adolescent and young adult internalizing symptoms in the South African context. And we wanted to explore this moderation separately in males and females, as the rates of internalizing symptoms tend to be higher in females compared to males. For this study, we used data from the birth to 20 plus cohort, which is the longest running birth cohort in Africa. And it consists of children born within a 7-week span in 1990 and followed up until today, we're in their 30s. And we had a sample of about 1,000. So within this sample, about 47% of families were living in poverty, which was defined as the number of site-specific assets, such as a television, fridge, or a car that the family owned. Over 90% of the sample consisted of families of Black African origin, and the prevalence of maternal depression in this sample was higher than in our Canadian sample, so it was about 18.5%. And again, about half of the sample were females. So in this study, mothers were asked to report on their own depressive symptoms in the past week using the PIT inventory, which is a validated measure in this particular context. And for our outcome, we had youth report on their own internalizing symptoms when they were 14, 22, and 28 years, using a variety of different measures, such as the youth self-reporting, the youth self-report, the general health questionnaire, and the self-reporting questionnaire. To assess socioeconomic adversity, we created a composite measure that consisted of poverty, so defined as the number of site-specific assets I mentioned earlier, parental level of education, parental age at child's birth, and the level of household crowding. And then finally, we adjusted for child level factors in the association. And in this model, we use two different methods: group-based trajectory modeling to estimate trajectories of internalizing symptoms over time, and logistic regression to regress these trajectories onto maternal depressive symptoms. And so group-based trajectory modeling uses data from across all 3 time points to estimate the probability of each participant of scoring within the top 20% of the measure of internalizing symptoms at each age. And this type of modeling enables us to use multiple data points and to track how changes in internalizing symptoms develop over time. So we see here that about 11% of the sample fell into the high, what we call the high trajectory of internalizing symptoms, and the majority of the sample fell into this low trajectory. It's worth noting here that females were overrepresented in this high trajectory. When we regressed this trajectory onto our measure of maternal depressive symptoms, we found an adjusted odds ratio of 1.20, suggesting that children exposed to maternal depression at 6 months were more likely to experience higher levels of internalizing symptoms throughout adolescence and young adulthood. And then moving forward, we wanted to test the moderating role of socioeconomic status in this association for males and females. So what we see here is that for females, those who had less socioeconomic adversity, so higher socioeconomic status, and exposed to higher levels of maternal and lower levels of maternal depression, were more likely to fall into the high trajectory group. So this is counterintuitive, and this goes against what has been found in high-income countries, where the double risk of low socioeconomic status and maternal depression leads to poor outcomes. This wasn't the case for females in our sample. Whereas for males, we found the expected association, where boys exposed to higher levels of maternal depression and living in environments of high socioeconomic adversity were more likely to experience higher levels of internalizing symptoms. And it's possible here that there are specific cultural practices that might explain this association, both in terms of the different adults caring for young children, as well as how boys versus girls may be treated in this social context. So again, coming back to Goodman and Gottlieb's model, these findings suggest that family socioeconomic status may also moderate the association between maternal depression and child outcomes. And furthermore, that there can be interactions between the different moderators. So we found an interaction between child sex and family SES in moderating this association. So to conclude, I just want to bring us back to the overall objective of these different research studies, which was to identify why and for whom associations of parental depression with child development and mental health varied. And so the key take-home message I want you to take from this presentation is that there is a pressing need to expand existing theoretical models to consider how associations play out, not only with different outcomes, but also in different sociocultural contexts. If we want to be able to improve health outcomes across the globe, we need to understand how these associations play out in different contexts to ensure that interventions are developed that are targeted to the local population and culturally appropriate. Concerning Goodman and Gottlieb's model, our studies showed that child sex moderates both the direct and the indirect associations with cognitive outcomes in high-income country contexts. So moving forward, it'll be important to test these different associations in other social cultural contexts to see if we're finding the same consistent results. We also found that school engagement mediates the association with cognitive outcomes, but only in girls. So there's a need to better understand what other factors may potentially mediate this association in boys, and how these different, how this moderating role of sex plays out in different sociocultural contexts. And finally, we found that family SES interacts with child sex to moderate the association with mental health, with children's mental health in a middle-income country context. And of course, another key question moving forward in this research is to try to understand the role that paternal depression might play here. So not only would it be important to consider the potential interactions between maternal and paternal depression, but also considering how these interactions may vary in different sociocultural contexts where mothers and fathers may not be the only adults involved in caring for young children. I also just want to bring us back to this model just to remind us of the importance of this kind of work, of focusing on the early childhood period as a way of trying to decrease as much as possible the risk of non-communicable diseases later on. And also working to make sure that we're conducting research that applies to the majority of children who really, around the world, who live in low and middle income countries, and ensuring that interventions that are developed are cognizant and applicable to their different social and cultural realities. I just want to take a moment to thank my different collaborators across the Université de Montréal, the University of Exeter, McGill, Université Laval, and the University of Wits for their contributions to this work, as well as different funders for providing the funds for this project. Thank you all very much for your time, and I look forward to discussing with you.
So thank you, Marilyn. You've left us a lot of good time for discussion. So I'm sure there's going to be questions coming through on the chat, but we have a few from Dr. Bernatsky. Sasha, do you want to go ahead and ask your questions if you're there? Perfect.
Absolutely. Thank you so much. That was pretty awesome. So so many, I mean, congratulations. It was wonderful presentation as well as amazing work. So when I see things that are counterintuitive, I always think, oh, what could it, as an epidemiologist, what could it cause that? Do you think that it may have been something like, I don't know if this is going on in the 1990s in South Africa, but if there was some intervention that targeted, because we got kind of recognized that girls particularly could be in some countries could be particularly vulnerable if they don't have resources. So is it possible that there were some kind of initiatives on some scale going on in the country or in different regions that targeted resource poor girls so that they may have actually been able to catch up, and that would have left, so that it compensated that particular group, so that you see the effect of maternal depression more in high income girls or boys of any income level? That was one question. So maybe I'll ask you if you considered that, or if you think that's a possibility or not. And then if there's time, I'll ask my other question.
All right, thank you very much for that question. So in writing this paper and working with our colleagues from South Africa, that isn't one of the explanations that came up to try to account for it. It is very possible, but we acknowledged in the paper and amongst ourselves that we weren't sociologists, or we really didn't have the tools to better understand whether it was social factors or whether it was, government interventions that were being implemented that could have explained this. So this is really a situation where we need further research and perhaps qualitative research to try to understand what could be explaining why we're seeing this counterintuitive results, particularly for girls. And when we had this discussion with our South African colleagues, some potential explanations that came up was that girls and boys may not be treated in the same way in low-income families. And so depending on how much time they might be spending with their mother, that could influence the impact of the mother's depression on that child's later outcomes. So these were just some ideas that we played around with, but of course we don't have the concrete answers to identify why we found that association.
Yeah, but that's a very good point to bring it back to the people who would have that inner knowledge. Great. So my other question, if I'll take the time to ask it, is because you mentioned trying to control for confounders. So I'm just thinking of somebody who's depressed and is either prescribed medications antenatally or during the pregnancy, and we don't know 100% about the safety of in terms of long-term outcomes on kids for the whole host of in utero exposures of prescription drugs, and it might be hard in the data sets that used to control for that. And then the other question would, but I'm sure you thought of that. And then the other question would be, alcohol, tobacco, recreational drug, which maybe you were able to control for if you had some indicator of that. But I guess it always, the question always, remains, how well can we control for some of those factors? Any comments on that?
Right. So for the first part of your, sorry, just give me a moment to think. For the first part of your question, unfortunately, in both data sets, we don't have information on mother's experience of depression before birth, as they're both birth cohorts. So we started collecting data afterwards. But it is important to note that we didn't assess clinical depression. So we don't know if these mothers were diagnosed with depression, but we asked them to report on their depressive symptoms and then used cutoffs to determine the prevalence. So it's possible that they might have been experiencing high depressive symptoms, but we don't know if they were clinically severe enough to have been treated for depression. But in the Quebec cohort, we do have data on general medication use. We weren't able to specifically ask about antidepressants, but in another study, we did control for general medication use, and we didn't find that that had an impact on the association between maternal depression. And I believe that study, we were looking at children's verbal abilities. But again, it was a rough measure of medication use and not specific to antidepressants. And then regarding the second point around alcohol, tobacco use, recreational drug use, I think what we found is tricky in using that as a potential confounder is that there could be bidirectional association. So it could be that mothers who use drugs or tobacco and alcohol are more likely to be depressed, and their children are more likely to experience health problems later on. But it's also possible that mothers who are depressed are more likely to use those substances as well. And so then in trying to control for it, we may be, I don't want to use the word confounding, but we may be miscalculating the direction of that association there.
It's tricky with the directionality of these. Mark Roger. So Dr. Roger, do you want to ask your question? Yes, go ahead.
Yeah, sure. Just sort of thinking about Sir Bradford Hill's causality criteria and strength of association and strength of exposure being associated with outcomes. Is there any data on subclinical depression and link to childhood development, or at the other end of the extreme, severe depression in either parent with hospitalization and outcomes in the kids? Is there a gradient effect?
So there is a gradient effect, but some systematic reviews and meta-analyses that have been conducted don't always find a significant gradient effect. And it depends on the outcome that's being studied. So in our systematic review, we did look at differences between subclinical versus clinical measures of depression. And we found that boys exposed to clinical maternal depression had significantly worse outcomes than those exposed to subclinical levels, but that wasn't true for girls. But then I know in another meta-analysis where they focused on a variety of children's mental health outcomes, they haven't found that same significant gradient effect. So it seems to depend on the outcome that we're looking for. I will add the caveat to say that in those studies, most papers tend to use a subclinical measure of depression. So it could be that we don't have enough largely powered enough studies using a clinical measure of maternal depression to really tease out the strength of those associations.
Thank you. Helen, do you want to ask your question? If you're there.
Yeah, sure. Sorry. So my question is more related to, I can imagine that someone experiencing depression, whether they have a support system or whether they're in a perhaps high conflict relationship or a high conflict environment, the children might be also affected by that, if that was whether a confounding variable was controlled for in any of these studies, if marital status or quality of perhaps romantic relationship affected the children or affected the mother, and there was a kind of two-tier or like a effect on children and the depression symptoms of the mother.
Mm-hmm.
Thank you.
That's a great question. Unfortunately, we weren't able to control for that in either of our studies, but I am working with a PhD student now who's sort of taking the next step in my research using the Quebec data and testing the interactions between maternal and paternal depression. And in that, we're going to be looking at also the quality of the spousal relationship and the presence of marital conflict to see how that might impact the association with children's mental health outcomes. So that is something that we're looking into.
Oh, that's great. Thank you.
Thank you.
So I have a question, Marilyn. So a couple of things. When you were showing in the first study, the associations with test performance measures and cognition, a lot of the measures were kind of in that 0 to 1 range, 0.1, 0.3. What were we looking at? Were we looking at changes in scores? And I couldn't appreciate what the magnitude of the relationship was. Was it a trivial relationship? Was it a strong relationship?
This is the systematic review. Is this what we're?
I think so. Yeah, like I don't know what 0.36 means. What kind of
This
a
is-
scale is this? Yeah.
This is a standard. The standard.
So it's standardized?
Yeah,
Okay,
these
so
are
it's like
standardized
0.36 of a
standards.
standard deviation. Okay,
Yes, exactly.
so you have to clarify that to us epidemiologists because we don't always.
Sorry.
And I guess my other question is the notion of socioeconomic status and depression. So if I understand correctly, we're starting from the point of maternal depression, yes, no, and we're looking at childhood outcomes, and we're assuming, or we're suggesting that socioeconomic status is a mediating variable in terms of the impact of depression on these outcomes. Is that kind of how you formulated it, or?
We're assuming that socioeconomic status is a moderator.
Is a moderator. Okay.
So it's either going to socioeconomic status, let's call it socioeconomic adversity, yes, no,
Yes.
is going to increase or decrease the strength of the association between maternal depression and the child outcome.
So how does that, because socioeconomic adversity could provoke maternal depression itself, right? So in constructing your models, like how can you account for that? Because I would postulate that it's the socioeconomic adversity that's kind of driving the mood or disorder in the mom, and then some of it may impact the child, but some of it may be the adversity itself also impacting the child. So how have you kind of worked on that mathematically, which is tricky? Yeah.
Right. So in this model, because we were focusing on moderators and not mediators,
Okay.
directionality wasn't as important.
Okay.
So we were taking the moderators at the same time point. And I guess another way we could phrase it is that maternal depression moderates the association of socioeconomic status on child outcomes.
Okay. It could be
But
either.
the key concept to understand here is really looking at cumulative adversity, is being exposed to maternal depression and socioeconomic adversity giving you worse health outcomes.
I see. Okay.
Regardless of whether one causes the other. If we were looking at mediation, that would be a completely different question.
Got it.
Because our interest was really more risk, worse outcomes, or is having only one of these risk factors worse or better for you?
Okay.
I don't know if that gets
Yeah,
to
no, it makes sense. Yeah, it does make sense. Are there some other, oh, here we go. Fax and Mawali, would you like to ask your question? Please go ahead.
Yeah, so thank you very much, Dr. Ahun, for such a wonderful presentation. So I'm not in the field, so I was seeing it from a naive point of view. It seems to be a case of nurture versus nurture. And I was wondering if this is basically a one-way street. From the psychopathology seems to go basically from the mother to the child, and is there the other way around? And the other thing is what about those children who resist stimuli? You know, I'm sure they must be. They're not responding the same. My understanding is that I mean, I grew up in Africa, and I get the conditions can be quite very dire, but then there are not all children seems to be responding the same. Yes, those children who are not succumbing to all the adverse effects that you are talking about. Mm-hmm. So how is that accounted for in your calculations?
Right. So thank you for that question. To respond to the first part of your question about nature versus nurture. So in these studies, I'm acknowledging we weren't looking at genetic factors at all. So I can't really talk about the nature aspect, but I can say that research on the impact of maternal depression on child outcomes shows that it's both genetic and environmental. So looking with research that's been conducted with twin families and also in adopted families, the depression of an adopted mother does increase the risk of her child getting depression. So it's not just a question of the mother passing on her genes to the child. There's also something about the environment that's created within the household that also increases the risk of the child getting depression. And so related to that, you had a question about whether it's a one-way street or not. It isn't a one-way street, at least in terms of children's mental health problems. So there are bidirectional associations where being exposed, and I'm using maternal depression as an example here, but it's also possible that we could be talking about paternal depression here, where, being exposed to maternal depression can increase a child's risk of experiencing mental health problems. And then having a child with mental health problems then also further increases the mother's risks of depression. And it just sort of goes back and forth with, this exposure to mental health at the mother and the child level, sort of furthering the risk in the other person. And so it is a bidirectional association. And then in terms of your second question, if I understand correctly, you are asking about the children who are exposed to maternal depression, but don't experience any health problems. Is that correct?
Yes.
Right, that is a great question, one that I don't specifically focus on in my research, but there is an increasing literature looking at resilience. So some children exposed to maternal depression don't have an increased risk of mental health problems or cognitive problems or any other problems. And there is research trying to better understand what are the individual level factors that protect these children from the adverse impacts of maternal depression. So it's not something that I specifically focus on in my research, but I do know that there is a growing interest in that within the literature.
Thank you very much.
Thank you.
Are there some other questions? Yeah, Sasha's back. Go ahead, Sasha.
Sorry, I always
Oh,
ask
never
disproportionate-
apologize. Oh my God.
So, it's so interesting because I feel like kids can get depressed and we might not appreciate that or know it. And I'm wondering if some, because some of it is genetic. So thinking about genetic component, is it possible that when a kid's not achieving well, it's because he's depressed and we're not picking it up maybe? And can you think of a way where that, I'm assuming that might be something that's genetic. So do you think that could, conceivably be a reason why boys and girls end up in different places when the mother's depressed?
So if I'm understanding your question correctly, it's that for a boy exposed to maternal depression, the reason why he may not be performing well in school may not be because of the maternal depression, but because the boy himself is experiencing depression, and that's then what leads to poor academic outcomes. It is feasible. So we do know that boys are more likely to experience behavioral problems when exposed to maternal depression. And in that paper, that's when the discussion, that's one of the things that we thought about. Maybe boys' behavioral problems could mediate the association, since we didn't find that school engagement or pure victimization could be an explanatory factor. So that is a possibility.
I was also wondering, do you see the day when schools will be able to measure all these constructs that are so important and then provide some resources to those poor kids?
That is a great question. And I think it is feasible, perhaps not using the same measures that we did in this study, because, it was a birth cohort and it was quite an intensive measure. But I do know that there are population level measures that exist, like the early development instrument, that can be widely applied to a large group of students without overburdening teachers, so that we can have these data and analyze them and then use them accordingly to develop interventions. So I do think that's a possibility, but we do have to be mindful of not overburdening teachers who in some systems already have quite a lot on their plate.
For sure. I mean, I'm even thinking, you know, things like times a kid gets sent to the principal's office, you know, is probably a very good indicator of poor outcomes, but we don't see the kid as somebody needing more resources. We, you know, sometimes. Thank you.
You're welcome. Thank you.
So Marilyn, what is your intervention study that you're going to design to kind of disentangle some of this? Because I have the feeling that there's a limit in observational studies to really measure and identify all of these factors. So have you had some thoughts about, you know, what you think the key drivers are and how you'd address them realistically and as you say, resource-strapped schools and those kinds of situations?
Yes, so the interventions that I've been thinking of, I'll admit, are more before the school stage. So I've really been trying to focus on the very early childhood period to prevent, you know, problems developing even later at the school stage. And I've been focusing on parenting and parental depression and trying to tease apart which intervention is really needed to help children improve. So within the literature, we know that parenting interventions improve child outcomes. That's been proven many times, both in low-income countries and in high-income countries. And these interventions tend to be group-based, so really focusing on that social support aspect, inviting other adult caregivers to participate, acknowledging that mothers aren't the only ones responsible for caring for children. Then on the other side, we have parental depression interventions, which we know are successful in decreasing the level of depression in parents, but we don't know whether they then lead to improvements in child outcomes. So they're just sort of the standalone that we're able to reduce a parent's depression, but then the parents might not have the necessary resources to provide the best care for their children. And so the intervention that I'm working on developing right now is being able to test the different mechanisms of these interventions. So having an arm where we just focus on parenting, an arm where we just focus on parental depression, and then an arm where we develop a bundled or multi-component intervention that integrates content both on parenting and parental depression as a way of trying to more holistically address parenting needs and comparing these different interventions and testing their mechanisms in terms of improving child outcomes as well as parental well-being. So that's the direction that I'm moving towards in my work now.
Very nice. I'm almost tempted to tell you to add another arm or replace one with a bit of income supplementation, just to see if that is really driving things. Yeah.
And there are a few parenting interventions that I've tried to do that as well, as focusing on conditional cash transfers.
Well, very important work. Thank you so much. If there aren't other questions, we'll release people a little earlier, but it shows the interest in the topic and the speaker that we had such a lovely turnout. So thank you so much.
Thank you so much for having me. Appreciate it.
Thank you.
Thank you.